Good afternoon, sir. I am a postgraduate student of ENT and I have come here with my problem of vertigo. I have read your books regarding neurotology and so on, and I have heard from my friends that you are a best person in this field, so I want to contact
Fine.
you.
Tell me, let's go on. Well, what is your problem? On phone you had requested that you want to meet me outside my clinic, but you have come to me as a patient or for training in our vertigo clinic. And why outside the clinic? What is there so very private in vertigo that you did not want to discuss it in the clinic?
No, sir, I am here primarily as a patient of vertigo seeking some ethical and logical management of my problem, which I am not getting anywhere. I am extremely frustrated not only by my disease that I am suffering from, but also the way it is being managed by top-notch doctors. I do understand that many medical disorders are not curable, but there has to be some kind of rational management and a definite scientific approach to treat the disease. Doesn't that happen for vertigo, sir? I am a medical person in a postgraduate institute and I have access to all the medical literature, but I am sad to say, sir, that I feel that my medical problem is being handled irrationally and maybe I have the audacity to say very unethically by medical professionals.
Why do you say so?
I am only offered some drugs on anti-vertigo drugs just to camouflage my problem and asked to continue it for an indefinite period. None of these are capable of reversing the pathology, but all the drugs I find have some serious side effects and are unscientific in their pharmacological actions, but are prescribed so rampantly, probably as there is no prescription auditing and doctors are not made accountable for. I have studied in published literature, some of which I am carrying now, about what I understand the management of vertigo is carried out by practitioners are very irrational, unethical and pharmacologically illogical. I would love to be proved wrong, but if you give me some time, sir, I can elaborate my point. As you are a doctor specializing in vertigo, I thought you will be able to guide me for something better, to find out some rational solution to this problem. What is more rational and what is irrational in the management of vertigo? As the more I am visiting doctors, the more I am reading up on the pharmacotherapy, the more confused I am getting. Even I am not relieved of my problem of vertigo. Even if I am not relieved of my problem of vertigo, I want to know how and if at all the symptom of vertigo can be approached rationally and ethically.
You have all the time with me, and since you are a medical person who has read up the pharmacological aspect of management of vertigo patients and have been to so many renowned specialists, I would want you to share your experience and knowledge with me. Please go ahead. By the way, have you done any tests for vertigo?
Well, I have been visiting doctors of all specialties in various cities in the country, and maybe you are the 25th or the 30th doctor in this list of my specialties that I have visited to get relief of this vertigo. And I have spent fortunes visiting different doctors and have done the weirdest of investigations that include MRI brain, MR angiography, venography, carotid Doppler, CT scan of neck, high resolution CT scan of inner ear, numerous pure tone audiometry, BERA, 4 times ENG and blood tests that include vitamin B12, homocysteine, vitamin D3, vitamin E levels, nerve conduction studies, somatosensory evoked potentials and whatnot, many more. Except for some minor abnormalities in the audiometry, and 2 of the 4 ENG tests, none of the tests that have been repeated several times, yet they have not yielded any abnormalities. But doctors keep on asking the same test, prescribe the same medicines, which I as a medical person understand is irrational, and they have dangerous side effects. Yet then I take some, sometimes very reluctantly, but I was never really cured. As this test too, I was not unhappy the way the function, the vestibular function test was conducted. Two of the ENG tests that were found to be normal were conducted by ENT doctors in their clinic, but other two which were ENG reports which showed abnormal, the tests were conducted by some technicians known as audiologists, which I later learned that they have no formal training in interpreting the vestibular function test as a part of the curriculum, whatever it may be. The doctors accept the crap and they say the reports that these technicians send and take clinical decisions, sometimes even without looking at the graph. Not surprising, in one of the ENG tests I was diagnosed central lesion, another I was diagnosed bilateral peripheral vestibular lesion. And the irony, sir, that though I was advised different tests by different stalwarts whom I had visited, yet irrespective of what the ENG test was saying, I was prescribed the same anti-vertigo drug. I was prescribed beta-histine when the ENG test was reported normal, when it was reported bilateral peripheral vestibular disorder, and also when it was reported central vestibular disorder, every time I was prescribed beta-histine. So sir, why was I at all advised the test?
You young man have reason to feel agitated. Well, you said that you had been to different specialists. To which specialists have you been?
Sir, initially I started with general physicians, then I graduated into medical consultant, neurologist, orthopedic surgeons, gastroenterologist, cardiologist, ENT doctors, and even a couple of psychiatrists. I even visited an ophthalmologist. So other than gynecologist, I have visited all types of doctors, though of different disciplines, but the prescription remained more or less the same across all the disciplines.
What is the diagnosis that has been made by the different specialists?
Nothing very specific, sir, but in most of the cases the diagnosis was vertigo. Coming from a medical profession, I know very well that vertigo is just a symptom and it cannot be a diagnosis. But most of the doctors have diagnosed me to be suffering from vertigo.
I will first try to learn from you about your grievances against the different drugs, as you have studied extensively on the pharmacology of these drugs, and then go into your disease. I have no qualms in admitting that we clinicians are a bit pharmacologically challenged, except for a very few, and we go by whatever crap some of the small time medical representatives from the pharma companies come and teach us. Another thing which I need to admit is that the current consensus is that anti-vertigo drugs should never be continued beyond 3 to 5 days. In rare cases it can be extended to 7 days, but never ever beyond that. This is universally accepted, and in the guidelines on the management of vertigo brought out by the Indian Academy of Neurology, which has been endorsed by the different national and international bodies, it has been clearly mentioned that anti-vertigo drugs should never be continued for more than 3 to 5 days. The anti-vertigo drugs are specifically symptom relieving drugs, and except for beta-histine in confirmed Meniere's disease, which also is not universally accepted, none of the drugs have any curative value. They are nothing more than what paracetamol is in malaria or typhoid. This guideline needs to be put into practice. By the way, what drugs have you been prescribed for your disease?
Sir, everywhere I have been prescribed either beta-histine or cinnarizine, and sometimes prochlorperazine, and rarely mecyclizine and dimenhydrinate, and only once promethazine. Since I have been having these drugs for years, sometimes for 6 months at a stretch, sometimes for 3 months at a stretch, sometimes for 2 weeks, prescribed by all doctors, not ordinary doctors, they are very renowned and respectable ones. Then I migrated from doctor to doctor, and sometimes the same drug has been prescribed me to by a new doctor with a different name. Each of these drugs are extremely harmful, sir. I know that they have been prescribed empirically just to camouflage my symptoms, and with no thought of offering a cure, or sometimes, sir, completely without an indication. Like a strong antiemetic was prescribed to me for 3 months at a stretch, and even though I had no nausea and vomiting. Some of these drugs, sir, are not approved drugs of vertigo in many countries, but are freely prescribed in our country without any restriction whatsoever.
I am fully aware that betahistine and cinarizine are not FDA approved drugs, and I am not questioning FDA's decision. But both betahistine and cinarizine are not disapproved in Europe, and betahistine is one of the commonest anti-vertigo drugs used in Europe. Keeping this issue aside, pharmacologically, what do you have to say against betahistine and cinarizine?
Sir, you are a very learned person, very renowned in your profession, but if you please allow me a bit of audacity, I have with me the 11th edition of Goodman-Gilman, the famous pharmacological book titled The Pharmacological Basis of Therapeutics. When I tried to look up for cinarizine in the index, as it is mentioned in page number 832, chapter number 31, and not anywhere else in the book. Sir, can I please tell you what's the name of the chapter?
Yes, go ahead.
You will be surprised to know, sir, that it is the chapter titled is Treatment of Myocardial Ischemia, which is chapter number 31 in the Goodman-Gilman's book. This sent shoulders down my spine. I thought the neurologist who has prescribed me this drug has diagnosed me a case of myocardial ischemia. Well, cinarizine is mentioned in page number 832 under the heading calcium channel antagonist. This belongs to the same group of drugs as amlodipine, nimodipine, nicardipine, verapamil, etc. All these drugs have effect on cardiovascular system, specifically the cardiac cells. These drugs affect the depolarization of the sinoatrial and the atrioventricular node of the heart, and also affects the AV conduction. The chapter also mentions that all the calcium channel blockers approved for the clinical use decreases the vascular resistance and increases the coronary blood flow. They are also known to produce negative inotropic effect on the cardiac cells. I emphasize here, sir, once again, that this is the only place that cinarizine has been mentioned in this standard textbook of pharmacology. Though on doctor's advice, I did take cinarizine for a pretty long time, yet I felt extremely scared that whether I am having some problem is occurring in my heart or not, and I used to do an ECG every month. What is more important, that even after taking all this, the calculated risk on my heart, my attacks of vertigo continued unabated, and though the intensity of the attacks were a bit lesser. Then I stopped cinarizine, the attacks aggravated, indicated that thereby cinarizine did not reverse the causative pathology at all, in spite of taking my drugs for the last 6 months. I hope that this drug has not caused any permanent damage in my heart. Though some other former books like the 36th edition of Martindale's book, The Complete Drug Reference, has mentioned that cinarizine has depolarizing effect on vestibular cells, yet it is nowhere mentioned in Goodman-Gilman book. While taking cinarizine continuously for 6 months, I did have reduction in intensity as well as frequency of the vertigo attacks, but I also had tremendous drowsiness, dry mouth, occasionally headache, which according to published literature are recognized side effects of cinarizine. The drowsiness, dry mouth, some palpitation off and on were a big nuisance and increases the morbidity. But since vertigo was a bigger nuisance and my vertigo was somewhat under control, I did continue it. However, I did not have blurring of vision or GI symptoms, which too are expected on long continued use of Cinerezine. But sir, after 6 months, I did discontinue the drug as I got scared of getting Parkinsonism. There is enough of evidence in published literature that says that Cinerezine is known to cause acute and chronic Parkinsonism due to its affinity for the D2 receptors in the stratum of the brain. Literature also says that Cinerezine's antagonistic effect on D2 receptor is liable to cause mental depression, tremor, muscle rigidity, and akathisia, and tardive dyskinesia, etc. All these are features of drug-induced Parkinsonism. There is evidence that metabolite of Cinerezine that has caused an active role on drug-induced Parkinson's disease. It has been reported that 17% of the new Parkinson's disease are associated with long-term intake of Cinerezine or flunarizine. Though Cinerezine induced Parkinsonism is commonly in elderly female and in those who have a family history of Parkinsonism, yet it can also occur in others who use it for a prolonged period. Cinerezine prevents the magnesium ATP dependent production of electrochemical gradient, which is crucial for the transport and storage of dopamine into the vesicles, and hence it lowers the level of the dopamine in basal ganglia neurons and leads to Parkinson's type of symptom. Over and above, this is also known to cause pedal edema. Martindale's book, The Complete Drug Reference, also mentions that Cinerezine can cause extrapyramidal symptoms and should be used with caution in patients suffering from hypotension, as it can further reduce the blood pressure, and long continued use can also cause weight gain. The more I read about this issue, the more I got confused, rather scared, and discontinued the drug. Now, because if I am allowed to choose between vertigo and Parkinsonism, I would rather choose vertigo and leave Parkinsonism alone, because Parkinsonism is a dangerous disease, as everyone knows.
After taking Cinerezine for 6 months at a stretch, did you feel any imbalance?
Yes, I did. I had reported that to the doctors, but he said that this was because I was not doing my vestibular rehabilitation exercises regularly. After that, I did it very diligently for a few days and the imbalance disappeared. Why are you asking this? Does Cinerezine induce imbalance?
Not really, but long continued use of vestibular sedatives, especially the ones that induce drowsiness, are expected to jeopardize the vestibular compensatory mechanism and induce some imbalance. Vestibular sedatives act by reducing the sensitivity of the vestibular labyrinth, and hence the brain is inadequately informed about the stability of the subject. Like all other vestibular sedatives, Cinerezine also reduces the sensitivity of the vestibular apparatus of the inner ear by inhibiting the activity of the vestibular hair cells. The vestibular hair cells sense body movement and send signals to the brain about movement. So, if the brain is not adequately informed about body movement, it cannot take the corrective measures, that is, the requisite motor activity to stabilize the person. This of course applies not only to Cinerezine, it applies to all vestibular sedatives. Reduction of the firing rate in the vestibular labyrinth or any inhibition of the vestibular nuclei reduces the sensory conflicts within the vestibular system. Sensory conflicts are very important for development of the vestibular compensatory mechanism. So, if sensory conflicts are reduced, as happens when any vestibular sedative is used, be it Cinerezine or betahistine or meclizine or prochlorperazine, the vestibular compensatory mechanism is jeopardized. The vestibular compensatory mechanism is the natural process that restores normal balance function after there has been an assault or damage to the vestibular labyrinth of one or sometimes even both sides.
Sir, hence do you mean to say that vestibular sedatives should never be used?
No, I never meant that. Vestibular sedatives like antipyretics in fever have a very definite role to play in alleviating the patient's symptoms and the physical distress that the subject undergoes when there is a damage to the balance system. But prolonged use of vestibular sedatives is very likely to jeopardize the vestibular compensatory mechanism, which is the mainstay of treatment for restoring normal balance function. Hence, it is not that the vestibular sedatives should not be used. They should be used for very short periods of time and should be discontinued as soon as the patient's acute symptoms subside. Current recommendation is that vestibular sedatives should not be used for more than 3 to 5 days at a stretch. Let us discuss some other drugs used in vertigo now. As you say, all drugs have been tried on you and you have extensively researched on all anti-vertigo drugs. Hence, you should know the best. You said you had taken beta histine also for a pretty long time. What is your contention on it, and what does all the books and papers that you are carrying with you have to say on beta histine?
Yes, I have taken beta histine several times in phases of 3 to 4 months as and when the doctors have prescribed me. I have taken it in dose of 8 mg twice daily, 16 mg thrice daily, 24 mg thrice daily and even 48 mg once daily. The only advantage that I have noted with beta histine was that it did not induce any drowsiness or dry mouth, which was a major nuisance with cinnarizine and even with prochlorperazine and dimenhydrinate. The 8 mg twice daily had no effect on me whatsoever, but when I was taking 24 mg thrice daily, I had the best result.
What do you mean by best results?
I meant reduction in intensity and frequency of the vertigo attacks. The 24 mg thrice daily dose suited me pretty well. I would like to add here is that for about a month I had taken a new salt of beta histine called beta histine mecyclate 12 mg thrice daily instead of the more commonly available beta histine hydrochloride, as I had read somewhere else that the bioavailability of beta histine is better in beta histine mecyclate, but the effect was not as good as beta histine hydrochloride 24 mg thrice daily. Moreover, sir, I consider beta histine as a very safe drug because in the course of discussion with some of my neurology and other ENT colleagues, I learned that beta histine does not jeopardize the vestibular compensation mechanism. This also gave me a lot of mental comfort. Though in the November 2006 issue of the Drug and Safety, there was an article by Dr. Sabine Jekthol and Wolfgang Warner, maybe I am pronouncing it wrong, that taking beta histine hydrochloride can cause different kind of skin allergies and skin related side effects of hypersensitivity like tingling, numbness, burning sensation, shortness of breath, etc., probably due to beta histine's role in increasing the histamine level throughout the body. Yet I did not have any such kind of noticeable problems with beta histine.
You had a better clinical response with 24 milligram beta histine dihydrochloride because beta histine dihydrochloride 24 milligram tablet has more of beta histine than a 12 milligram beta histine mesylate tablet. Beta histine has a dose dependent effect, which means more the beta histine, better the pharmacological action. Hence, your symptoms were more controlled with the 24 milligram beta histine dihydrochloride thrice daily dosage. The main advantage of beta histine is that it is a non-sedating anti-vertigo drug and hence less liable to jeopardize the vestibular compensatory mechanism. However, as it is a vestibular sedative, it is very likely to reduce the sensory conflicts and thereby jeopardize the compensatory mechanism in spite of all the hype created around it and it being promoted as the only anti-vertigo drug which does not jeopardize the compensatory mechanism, as it does not cause sedation and CNS depression. Reduction of sensory conflicts as well as CNS depression both are known to jeopardize the vestibular compensatory mechanism. The antihistaminic group of vestibular sedatives like sinerazine, prochlorperazine, meclizine and dimenhydrinate jeopardize vestibular compensation both by CNS depression as well as by reduction of the sensory conflicts. Beta histine does not cause CNS depression, but being a vestibular sedative, it is bound to reduce the sensory conflicts.
So, beta histine and sinerazine are considered to be more effective than other anti-vertigo drugs than dimenhydrinate, prochlorperazine and mecycline, as both beta histine and sinerazine increase the blood supply to the brain and the inner ear. How relevant is this fact in clinical practice, and is it really true that blood supply to brain and inner ear is increased by beta histine and sinerazine?
Yes, there is enough of evidence to prove that both beta histine and sinerazine increase blood supply to the brain and the inner ear. The mechanisms by which they do so has also been very clearly enunciated. Sinerazine has an anti-vasoconstrictive action by virtue of which any vasoconstriction in the smooth muscles of the blood vessels of the brain and the inner ear is prevented. This is due to its calcium channel blocking effect. Moreover, sinerazine also is effective in decreasing the viscosity of blood by virtue of which blood can flow easily through the narrow blood vessels of the brain and the inner ear. Beta histine is a selective vasodilator of the blood vessels in the brain and the inner ear, especially the inner ear. The H1 agonistic and the H3 antagonistic effects of beta histine are responsible for this. But the question is whether we really need to increase the blood supply to the brain and the inner ear in each and every patient of vertigo that comes to the clinic. Hypoxia of the brain and the inner ear is not the only cause of vertigo. It is one of the rarest causes of vertigo, especially the rarest cause of acute vertigo. Hence, if a 35-year-old patient comes to you with acute onset of vertigo, hypoxia of the brain or the inner ear or hypoperfusion of the brain would be one of the remotest possibilities. This can be an issue in old aged vasculopathic subjects presenting with chronic vertigo, but in such cases there would be other features of hypoperfusion of the brain like dementia, etc. It is well known that vertebrobasilar insufficiency cannot be the cause of isolated vertigo. If vertebrobasilar insufficiency is present, there has to be other features like dysarthria, dysphagia, some lower cranial nerve problems, some perioral numbness, etc. Hence, the issue of increasing blood supply to the brain and the inner ear in each and every patient that presents with vertigo is definitely not logical. Therefore, the enhancement of blood supply to the brain and the inner ear by beta histine and sinerazine is not of much clinical relevance in the treatment of vertigo, and it does not make them better anti-vertigo drugs than meclizine, prochlorperazine or dimenhydrinate. It would not be out of place to mention here that one advantage of beta histine in increasing the blood supply to the brain and the inner ear, as found in published literature, is that beta histine, by increasing the blood supply in the stria vascularis of the inner ear, decreases endolymphatic hydrops and is hence useful in the management of Meniere's disease. However, there is yet a lot of controversy on the mechanism of endolymphatic hydrops, and how much this is clinically relevant is yet controversial. Let us discuss some other anti-vertigo drugs as well. What is your contention on prochlorperazine? How good or how bad is it? What is the info that you have mastered on it?
Sir, please do not embarrass me, please. Sir, since you brought up the issue of prochlorperazine, the first thing I would like to know from you is that prochlorperazine is an anti-vertigo drug or an antipsychotic drug or simply an antiemetic. In the pharmacology books, prochlorperazine is mentioned in chapters which belong to the antipsychotic drugs and the antiemetic drugs.
Yes, it is an antipsychotic and antiemetic drug, and pharmacologically it falls into these two categories mainly. However, from the clinician's point of view, I can tell you that prochlorperazine is the best drug for providing symptomatic relief in acute vertigo. It may not be the most potent, but it is the best. Vertigo patients, especially those suffering from acute vertigo, are in most cases grossly distressed by the accompanying vegetative features like nausea and vomiting that usually accompanies acute vertigo. Prochlorperazine not only relieves the acute vertigo, but it also provides relief from the nausea and vomiting. It is an anticholinergic drug that blocks H1 receptors, the muscarinic type of cholinergic receptors, and the dopaminergic receptors also. The antiemetic effect of prochlorperazine is primarily due to its blocking of the D2 dopamine receptors. Dopamine is known to facilitate cortical arousal, and the behavioral changes induced by prochlorperazine, one of which is drowsiness and reduced alertness, is primarily due to its anti-dopaminergic effect and also partly due to its anticholinergic properties. The main problem with prochlorperazine is its extrapyramidal side effects such as acute dystonic reactions, pseudo-Parkinsonism and akathisia. This is a major limitation of prochlorperazine. In Goodman-Gilman's book on the pharmacological basis of therapeutics, prochlorperazine along with metoclopramide are listed as the two antiemetics in common clinical use that can cause Parkinsonism. Severe dystonic reactions after administration of prochlorperazine is more common in children and adolescents, and in countries like the United Kingdom, parenteral use of prochlorperazine is not recommended in children. Extrapyramidal side effects are seen in 2% of patients who receive the low dose of 5 milligrams thrice daily, and as much as 40% of patients have extrapyramidal symptoms where higher doses are used. It can also cause a life-threatening condition called neuroleptic malignant syndrome (NMS). So one has to be very careful and cautious in using prochlorperazine, especially in high dosage or for prolonged periods. All said and done, it cannot be overemphasized that in a patient presenting with acute vertigo and nausea vomiting, prochlorperazine is the drug of choice. The possibility of extrapyramidal reactions is very real and needs to be explained to the patient, especially so if the patient is seen in the OPD. In my practice, I often add diphenhydramine with prochlorperazine when I use it, as diphenhydramine can reverse the extrapyramidal side effects caused by phenothiazines like prochlorperazine. However, this may not be very ethical pharmacologically, but I just do it out of fear of inducing extrapyramidal reactions. Nowadays, prochlorperazine is marketed as a sublingual preparation in many places including India, but this causes ulceration in the form of local erosive cheilitis of the lips and tongue in many patients, but it disappears on withdrawal of the drug. In such cases, it is prudent to ask the patient to swallow the tablet instead of sucking it. As it is an antihistaminic anticholinergic drug with CNS depressant effects, it is bound to inhibit the vestibular compensatory mechanism. Hence, prochlorperazine should be used only for very short periods of 1 to 3 days, or say a maximum of 5 days, never ever beyond that, just to tide over a very acute phase of severe vertigo. Whenever this drug is used, the patient should be asked to start the vestibular rehabilitation exercises immediately, such that the inhibition of vestibular compensation can be counteracted by expediting the vestibular compensatory mechanism through the rehabilitation exercises. This of course applies for all anti-vertigo drugs including beta-histine.
So sir, what is the best use of prochlorperazine in safe dose? What if the acute phase lasts for more than 5 days?
The best use of prochlorperazine is in acute vertigo with nausea vomiting. It is never to be used as a long continued treatment for chronic or recurrent vertigo or for instability. A single oral dose of 5 to 10 milligrams is reasonably effective. In case the nausea vomiting persists, then a 5 milligram thrice daily for 1 to 3 days may be used, preferably never beyond that. If there is severe nausea vomiting due to which oral preparation cannot be used, a single injection of 12.5 milligrams usually suffices. Acute vertigo practically never persists for more than 3 days. In very rare cases, if there is very acute vertigo for more than 3 days, then it is prudent to change to other drugs like dimenhydrinate and cinerezine, but that too not for a prolonged period. Such a patient will have to be investigated very thoroughly, as peripheral vestibular lesions cannot last for more to 3 to 4 days.
Sir, I have once been prescribed this drug at a dose of 5 milligram thrice daily and asked to continue it for 3 months at a stretch. Why do you say that it should not be used for instability?
I would call it unethical, but we are not here to criticize other prescriptions. The other part of your question on why it should not be used for instability is very relevant clinically. What I meant was that not only prochlorperazine, no vestibular sedative, be it cinerezine, betahistine, meclizine, dimenhydrinate or any such drug, has any role in instability. Instability without significant rotating or spinning sensation occurs when there is a bilateral peripheral vestibular lesion, that is bilateral peripheral vestibular hypoactivity, or when there is a central vestibular disorder. It can also happen when there is an uncompensated vestibular lesion, or if the visual input is inadequate, as happens in darkness or in refractive errors, or if the proprioceptive input is insufficient, as happens in sensory ataxia. Vestibular sedatives do not have any role whatsoever in any of these conditions. Vestibular sedatives act by reducing the sensitivity of the vestibular labyrinth and by blocking the neural transmission of the vestibular impulses in the brain. If there is already a vestibular deficit, then administration of vestibular sedatives will further aggravate the hypoactivity of the vestibular labyrinths and hence increase the instability. If the instability is due to inadequate proprioceptive or visual input, we would need a very sensitive vestibular labyrinth to make up for or compensate for the reduced input from the other sensory input systems. In such a case too, if the clinician reduces the sensitivity of the vestibular labyrinths by prescribing vestibular sedatives, it will only aggravate the instability, because the brain would then be deprived, rather further deprived from the sensory inputs which are needed to maintain balance. If the instability is due to poor compensation after a unilateral vestibular damage, vestibular sedatives will reduce the sensory conflicts and in most cases even induce depression of the central nervous system, both of which are detrimental for the development of the central vestibular compensation. Moreover, most of the vestibular sedatives also inhibit cholinergic and histaminergic neural transmission. Enhanced neural transmission between the different parts of the brain is necessary for the development of vestibular compensation. So, vestibular sedatives will jeopardize this. In most central vestibular lesions that present with instability, there is some blockage in the higher vestibular pathways of the central nervous system. The vestibular sedatives act by receptor blockage, inhibiting the neural transmission in the higher vestibular pathways. So, the problem only increases. Hence, in patients presenting with instability and not the typical vertigo, that is the rotating spinning sensation, vestibular sedatives are practically contraindicated.
What about dimenhydrinate, sir? I presume it's a very safe drug and is used widely in Western world, though I have been prescribed this drug only once. I had continued it for 3 weeks and then discontinued it for the drowsiness it caused.
Dimenhydrinate is an anticholinergic drug and will have all the advantages and disadvantages of anticholinergic therapy. However, there is one very special advantage of dimenhydrinate. It is probably the only antiemetic drug without any extrapyramidal effects. And so, unlike prochlorperazine, it can be safely prescribed in those patients who present with acute vertigo with vegetative symptoms like nausea and vomiting. Dimenhydrinate is a vestibular sedative and has a depressant effect on the vestibular labyrinthine function. In patients who do not have an enlarged prostate or are suffering from respiratory disorders like emphysema, chronic bronchitis and glaucoma, it is a reasonably safe drug. As with other antihistaminic group of antivertigo drugs, concomitant use of alcohol or other CNS depressants is best avoided as they have an additive effect and impair the motor skills. Dimenhydrinate is excreted in small amounts in breast milk and so it is best avoided in breastfeeding mothers also. The recommended dosage of dimenhydrinate in acute vertigo with nausea vomiting is 50 to 100 milligrams 3 to 4 times daily for 3 to 5 days. It is not advisable to exceed this dosage as dimenhydrinate at 100 milligrams administered at 4-hourly intervals for 3 doses has been found to affect color discrimination, night vision, visual reaction time and stereopsis. So, one has to be careful.
So, how do you rate mecyclizine as an antivertigo drug?
Hey, this is pronounced as meclizine and it is not mecyclizine.
So, how do you rate meclizine as an antivertigo drug? It is not that popular among doctors here, though it is the most prescribed antivertigo drug in US. I have been prescribed this drug once and I had taken it for 6 weeks and then stopped it on my own.
Why did you stop it? Were you uncomfortable with it? Or were there any adverse effects? Or you did not find it effective for the control of vertigo?
No, not that it was ineffective, nor I had any problem with it. In fact, the cholinergic side effects were much lesser. Since I had read a lot about the side effects of the antivertigo drug, I stopped it. I knew it was nothing more than a symptom relieving drug which in no way was going to reverse the pathology that I was suffering from, and since I was symptom free for more than a couple of months, I discontinued it.
Yes, meclizine is a very safe drug. As far as I know, it is even approved as an OTC product by FDA for vertigo. It has no known teratogenic effect and its antiemetic and antivertigo effects are as good as that of dimenhydrinate. This is what the pharma books say, not what I am saying. Of all the anticholinergic or antihistaminic antivertigo drugs, meclizine has the least anticholinergic effect and hence causes less drowsiness. This is the plus point of meclizine. And this is an important issue in clinical practice, as any drowsiness induced by the therapeutic agent is often misinterpreted by the patient as increased vertigo and instability. Pharmacologically, meclizine is said to have a marked effect in blocking the vasopressor response to histamine, but its anticholinergic action is relatively weak, as it has only a slight blocking action against acetylcholine and hence it causes less blockage in the cholinergic pathways. The main plus point for meclizine, as claimed in most of the pharmacology textbooks and also as evidenced in clinical practice, is its minimal anticholinergic side effects. Anticholinergic side effects are a big nuisance in the antivertigo drug regime, and so a antihistaminic anticholinergic drug with minimal anticholinergic effects is a boon.
Do you, sir, mean to say that meclizine is the best antivertigo drug for symptomatic relief?
No, its antivertigo effect is probably less than that of prochlorperazine in comparable dosage. But if you ask me which drug is the most potent for symptomatic relief in acute vertigo, I would say it is scopolamine. It has a lot of side effects. It is very strongly anticholinergic, and there are availability problems also in our country. Its effects are similar to that of atropine, and so you know how strong its anticholinergic effects are. I would still maintain that when we are not thinking of anything else but just providing symptomatic relief in acute vertigo with nausea, vomiting, prochlorperazine remains the drug of choice, even though the efficacy of scopolamine is stronger and meclizine is safer. When we are prescribing a drug to an already morbid patient, we try to choose drugs that would not enhance the morbidity. The clinician has to carefully weigh the pros and cons or the effect side effect ratio and then take a very judicious decision. The commonest use of scopolamine in acute vertigo is as a transdermal patch that contains 1.5 milligram of scopolamine and is applied to the post-auricular skin over here. The drug is delivered over a period of 3 days. As it is a very strongly anticholinergic drug, it should not be prescribed in patients with glaucoma, especially the chronic open angle glaucoma, as the mydriatic effect of scopolamine may enhance intraocular pressure. It should also be used with utmost caution in patients who have urinary bladder neck obstruction or intestinal obstruction, and the prescription should specifically mention that patients should avoid activities that require mental alertness, such as driving a car or operating dangerous machinery. Scopolamine, like the other antihistaminics, should not be used with CNS depressants, other antihistaminics, tricyclic antidepressants and muscle relaxants.
Sir, we have discussed only about the drugs that can provide symptomatic relief in vertigo. But sir, vertigo is just like fever, a manifestation that is a symptom of some underlying disorders. Patient having fever presents to a doctor, and the doctor may use symptom relieving antipyretics for 3 to 4 days, but always tries to find out the cause of fever and treat the underlying cause. No doctor would ask the patient to take antipyretic eternally. The very basis of the medical management for all medical disorders is to find out the cause and treat the cause rather than camouflage the symptoms. Why is that this principle and ethics is often forgotten when it comes to the management of vertigo?
The same principles apply very much to the management of vertigo also. There is no denying of the fact that vertigo or imbalance is just a symptom of an underlying disorder, and the underlying disorder needs to be identified and treated, and that is what constitutes ethical management. If a proper clinical history is taken and the clinical neurological tests and the requisite neurological investigations, that is the vestibular function tests, are carried out, a very definite diagnosis can be made in most patients presenting with vertigo or imbalance. Once a definitive diagnosis is done and the underlying cause identified, there are very specific therapies for the different medical disorders that can present as vertigo or imbalance. The commonest cause of vertigo is BPPV, for which there is no medical treatment whatsoever. It has to be corrected by one of the liberatory maneuvers like the Epley's or Simon's maneuver or some other such maneuver. Migraine related vertigo has to be treated by a specific drug regime of migraine prophylaxis like divalproic sodium or flunarizine, and the beta blockers like propranolol and a drug like amitriptyline. Psychogenic vertigo and phobic postural vertigo has to be treated by SSRIs, benzodiazepines, etc. Vestibular neuritis is treated by anti-inflammatory agents like steroids. Meniere's disease has to be treated by diuretics like acetazolamide, hydrochlorothiazide, etc. Labyrinthitis needs to be treated by antibiotics or antivirals. Multiple sclerosis is to be treated by steroids. Sensory ataxia, peripheral neuritis, posterior column lesions and myelopathy by suitable neurological methods, and so on. All these conditions can be very easily diagnosed and very effectively managed.
So sir, can we summarize this lengthy and fruitful educative discussion on medical management of vertigo So I feel we can conclude, number one, for effective and ethical management of vertigo, we need to identify the underlying cause and treat the cause, and not merely camouflage symptoms by prescribing anti-vertigo drugs for a prolonged period. Number two, maybe most of the so-called anti-vertigo drugs have serious side effects which must be used with utmost caution, and the patient should not be put into unnecessarily and an avoidable risk by irresponsibly putting them on drugs for a prolonged period. Now, this is all the more relevant as practically none of the drugs will reverse the causative pathology and are capable of curing the patient. Number three, maybe the anti-vertigo drugs may be prescribed but to a maximum of 3 to 5 days and should be stopped as soon as the acute symptoms subside. And if proper history taking and clinical examination along with the requisite vestibular function test are carried out, the cause of vertigo can be identified in most of the patients, and a suitable corrective therapy can be instituted. So sir, thank you very much for your time, sir, and for showing some more light at the end of the tunnel. Now I am convinced that vertigo can be very well managed ethically and rationally like all other disease, and that symptom relieving anti-vertigo drugs have their own place in the management of vertigo, but the cause of the vertigo needs to be identified, and once the cause of the vertigo is identified, this dreadful disease can be cured. Thank you, sir, for all the information that I got, and now I am really feeling a bit relieved.
Yes, and another thing is that I hope that you will take up neurotology as your profession and you will provide ethical treatment to all the patients of vertigo that you see. Okay? Sure. And wish you all the best. Let's hope that we can get you out of your vertigo problem forever.
Thank you, sir.
That is possible.
Thank you,
okay?
sir.